does a lot of the cortisol, glucocorticoid production too. So those middle two layers kind of are a little bit fuzzy where they make both of them. Yes, we've got this inner medulla. We've already talked about that. We'll bring him up again in a minute. So you know the adrenal gland now, and you at least know anatomically, this is an all-endocrine dude. He makes hormones. And we ended on this slide showing you the main classes and who is like the poster child representative of each of the classes. For the mineralocorticoids, which we talked about, makes you think minerals. Minerals are ions. We're talking sodium and potassium, in particular sodium. The main guy there is aldosterone, for sure. It's the most important family member. It means there's others. We'll leave that to your advanced phys class to teach you that, because now aldosterone, he's enough. For the glucocorticoids, well, and as its name suggests, has everything to do with balance. We talked about briefly, so I guess it's worth repeating, aldosterone's target is kidney tubules. Causes kidney tubules, like every good steroid hormone does, to change the genes that they're expressing. And the gene that gets turned on is the gene for sodium-potassium pumps. So I'm going to pump sodiums back into my body, and rather than lose them in urine, I'm reclaiming them. Water follows it, blood pressure goes up. So you cannot keep your salts in balance, especially sodium, without aldosterone. As a matter of fact, you're dead in a day or two without aldosterone. We've done that to experimental animals, to mink and to rabbits. It's a big deal. Glucocorticoids make you think of blood glucose, right? Or glucose. Cortisol is the champion here. You've heard of cortisol. There are synthetic derivatives, cortisones, prednisones, steroid shots, and you've heard of all of that, and they have application in a lot of other places than here. But cortisol is a blood glucose raiser. It elevates your blood glucose. Matter of fact, cortisol is referred to as a glucose-sparing hormone. It's going to make other tissues burn lipids so that I'm saving glucose for my brain, because your brain is a one-trick pony, kind of stupid, can't burn anything else but glucose without consequences. So it affects how I'm dealing with and treating the macromolecules. Cortisol is critically important. It is your stress hormone. Help you deal with stressors. Gonatocorticoids, yes, the adrenal cortex is a site of sex hormone production, not just testes and ovaries, right? This also makes it, and predominantly we're keyed in on this male androgen, DHEA, dehydroepiandrosterone, and these aren't going to be the most important effects that we talk about today. Really, adrenal cortex comes down to aldosterone and cortisol, and we're going to pound out all their details. And we'll dabble a little bit here, but that's not as critical as the others. So, you're caught up. Now we got to move on. Number one, you will not memorize this table. Okay? So, unfreak out. But this is provided for you from Merib to have a great summary, a great overview that you can use to review the material for all the adrenal hormones, both the medulla and the cortex. What turns on and stimulates their release? Who are the targets and what does it cause the targets to do? And what happens if we have too much or too little? All of the things that I'm going to care about on this table, we're going to talk about in subsequent slides. They're going to be there on your list. That's where you're going to make sure you can do it, not memorize this table. Because this table is going to contain stuff that you're not going to have to really worry about. But it's pretty okay to have a review, like a little Cliff Notes page. Right now, while we have a chance, we want to talk about adrenal corticotropic hormone. Remember, ACTH comes from the anterior pituitary, from the cells there called corticotrophs. They're stimulated by hypothalamus little releasing factor, CRH, corticotropin releasing hormone. That's what adrenal corticotropic means. It's the same meaning as thyroid stimulating hormone, which we kind of went, duh, what does that do? Stimulates the thyroid to make its hormones. You learned that yesterday. ACTH, what does it do? Makes the adrenal cortex make its hormones. It is the only reason that cortisol ever gets released. ACTH is responsible directly for cortisol. But notice this aldosterone paragraph. What does it say right by ACTH? Doesn't hardly matter. It's only a little bit, only a minor influencer. That means, it should beg the question, you should say, well, then what makes aldosterone get released? If it isn't ACTH, well, it does. If ACTH levels go up, so do aldosterone levels go up. But you can cut out a pituitary gland from an animal, remove it completely, and see that aldosterone levels are untouched, balanced, perfectly normal. Because more important for aldosterone production is blood pressure. The renin-angiotensin-aldosterone mechanism that you haven't learned yet, but we'll pound those details out in Unit 4, which is week after next when we get in there, will show you what's the main stimulator. Actually, angiotensin 2 is a main stimulator of the adrenal cortex, zona glomerulosa, to make aldosterone, followed second place by blood levels of potassium. And ACTH, though receptors are there, is only the minor role, where blood pressure control is how you get aldosterone out. Okay, so other than that, this table is just there for fun, and now we talk about these will be the details that test questions will come from. And let's start with, these are all steroids. What do you know about steroids? Based on the cholesterol molecule, this big ring structure. Do they like water? No. How are they going to get around in you, big bag of water? They got to have transporters. You have public transportation in your blood. Your green STA buses that'll haul anybody, anywhere, have a pass or pay the bill. Sometimes you even cop a ride for free because you're cheating the system, whatever. Your public bus is called albumin. Ever heard of albumin before? It's the egg white stuff of eggs. We make our own albumin. That's chicken albumin in your egg. Albumin is a liver-made general public transport bus. Any hydrophobic anybody can hit a ride on albumin. That's how aldosterone and the androgens, DHEA, get around. We're going to leave it to you to just hop on the public transport bus and get yourself where you got to be. That wasn't true for thyroid hormone, right? It's hydrophobic. We made a limo for it, its own private coach. Cortisol is special enough that most of the time it gets its own private bus. The liver makes this guy, corticosteroid binding globulin, or better called transcortin. This is cortisol's private bus limo that nobody else gets a ride on but cortisol. So whatever the mechanism, we indeed have mechanisms to transport these hydrophobic steroids around my body. Because even if we're talking adrenal cortexes, like right here, it's far removed, even though it's just next door neighbors. It's got to get in the blood and get to the kidneys where it's going to make effects. So it's got to have a ride. That's pretty easy to see. Now let's go through what's the consequences, what's the causes, what's the consequences and symptoms if we had elevated levels of each. Aldosterone, cortisol, and DHEA. And then we'll do the what would happen, what would cause it, what would be the consequences if we didn't have enough of those same three. Hypers and hypos, we told you that's what we're going to do. Now we're going to do it. Aldosterone hypersecretion can be referred to as primary or secondary. Primary hyperaldosteronism is less common. This would be like a secretory tumor in your zona glomerulosa layer of your adrenal cortex. And it would just dump out crazy, stupid high levels of aldosterone. Okay, that would have some consequences. We'll get into that in a second, but that's not terribly common. Secondary hyperaldosteronism is more common. This is where you're going to have your blood pressure controllers. That's how you abbreviate the renin-angiotensin-aldosterone system is RAA. And you could have that be elevated, and that would be, because it's the primary stimulator anywhere, that would increase and elevate aldosterone production. Okay, so what? Whether it's primary or secondary, doesn't matter. I got too much aldosterone. What are the consequences? I'm just going to give you vocab words, and we're going to talk through them because you're wordsmiths by now. You know how to take them apart. The typical symptoms of too much aldosterone are hypernatremia, hypokalemia, hypertension, and edema. Know what those words mean? Start at the easy other end. What's edema? Swelling. Poofy tissues. You have edema. What's hypertension? You know that? Don't be shy. High blood pressure. High blood pressure, is going to work my pump out too hard, right? Going to take years off my life and got to get fixed. What does hypernatremia, hypokalemia mean? Do the first one. Hyper means too much. What's natrium? Na. Sodium. I have too much sodium around. This is actually the cause of the hypertension. Too much sodium, water's following sodium around like a little puppy dog. This means I put way too many sodium potassium pumps in the kidney tubules. We're pumping back and withholding all the sodium. Water's following. My blood pressure goes up. My tissues are swollen. I'm peeing out all my potassium. I'm hypokalemic. It's gone. It's lost. Not necessarily deadly tomorrow place to be, but certainly not a great place to be. And we need to fix it or you're going to cut lifespan off. What if I had too much cortisol? Well, this is a bigger deal. This actually gets its own clinical syndrome name. Hypercortisolism is what the very definition of Cushing's disease is. Have you ever heard of Cushing's disease? Cushing's disease, you see that, it means too much cortisol. Caused by, you could have a hypothalamus and pituitary whack job, where you're either making too much CRH from the hypothalamus, or too much ACTH from the anterior pituitary, would result in way high cortisol levels. You could have the adrenal gland itself, the zona fasciculata or reticularis layers with a tumor that was secretory in nature. That would elevate cortisol levels. Or you could have an adenoma, a secretory tumor, in some other place like your mesenteries of your guts, your bone, your lung, some other tissue can have an ACTH secreting tumor. Makes it imperative for you to go find out what the cause is. What went wrong, you know? Let's don't go mess up with your adrenal gland if you got this tumor over here in your lungs that's making ACTH. Let's go cut it out. Oh, hyperaldosteronism, Cushing's syndromes can be alleviated. It's imperative that we find out where's the problem. Doesn't matter which one of these is the problem. Cushing's syndrome, hypercortisolism, presents this list of symptoms. You will be diabetic. It's not an if, it's not a threat, it's a when. If you have elevated cortisol levels, you will be high blood glucose levels. That's what hyperglycemic means. You will have spillover and glucose in your urine. That's what glucosuria means. All of this caused by, number one of the high level targets of cortisol is your liver. And cortisol stimulates your liver to go into glucose production mode. Remember the word gluconeogenesis? Making new glucose from other substrates, preferably amino acids. So because of this going crazy liver action of making new glucose, you're going to have diabetes. Doesn't mean your pancreas is whacked. We'll talk about that later today. It's caused by the excessive cortisol. You're also going to have a moon face and a buffalo hump. That's this weird fat deposition on your face. Your cheeks are going to be like a male orangutan. And you're going to have this Quasimodo hump on your back. That looks pretty sexy, doesn't it? A orangutan face, little buffalo Quasimodo hump on my back because of hypercortisolism, Cushing's syndrome. You see that in a picture, clinicians, it ain't hard to connect the dots. Oh, we know the problem. You're also going to have your muscles be destroyed. You're going to be increasingly weaker and weaker and weaker. We're going to be degrading your myofibrils in your muscle. Why? Because we're using those amino acids in your liver to make glucose. Because it's turned on to stupid high levels. It needs substrate. It prefers amino acids. We'll rip proteins apart so that we can make this high levels of glucose. Not a good thing. Got to find it, got to fix it, got to treat it. What if you had too much DHEA, too much of the gonatocorticoid class? You could experience androgenital syndrome, which means make a man out of you. Depends on who you are. And how scary this would be depends upon which population subset you fit in. Girls, all of you, post-puberty, what would it do to you? It would masculinize you a little bit. Your skin wouldn't be as soft and supple. You're probably going to start showing man hair growth patterns. That's what hirsutism is hairy. So you're going to grow a mustache. Is that going to kill you? Shave. You're going to grow chest hair. Whoop-de-doo. Doesn't hurt your feelings, it's not really critical, but it's kind of annoying, and it would be a clinical condition that you would see. That's how androgenital syndrome would present in an adult sexually mature female. A lady in my town had 7 kids and grew a goatee thicker than her husband's. And I'm not kidding, and it's not a lie. I don't want to put her picture up here because that's not appropriate, but I'm not kidding. She had to shave because she probably had excessive adrenal cortex function, too much DHEA. Perfectly functional female, just had male growth hair patterns. If you were an unborn girl, fetal period, developmentally in utero, little girl trying to grow, you would be devastated by excessive DHEA levels. It would create in you pseudo-hermaphroditism. Is that a word that you can take apart and know what that means? What's a hermaphrodite? Got both sex organs. We aren't hermaphrodites. We're very distinctly female and male. It's not just external decorations that are different. Our whole physiology and some anatomy is different, potentially. It's not true in other critters, like earthworms come to mind. An earthworm that you pull out of the ground, big, lovely, gnarly thing, is a boy-girl. It's both. It's got ovaries and got testes. Can't breed himself, because that'd just be weird. But he gets another earthworm, and they copulate and trade gametes and impregnate each other. But they are true hermaphrodites with both mature sex organs. Pseudo-hermaphroditism is a crazy thing because it is fake. That's what pseudo means. Congratulations, you've just had a baby. You go look down to the lower 40 to see what the package is presenting, right? What are you going to do when it's ambiguous genitals? And you look at it and, yeah, okay, what is that? I'm not sure. Is that a little boy or is that a girl? It's going to be drastically different. Weird enough to cause some problems, and it's really, really sad when it happens. If you were a pre-pubertal boy, I have a picture of this. I elected to not put it in here because it might be too disturbing. I got a picture. I think the kid's 6. If you want to see it, I'll pull out the Guyton medical physiology textbook and I'll show you. It's got his face blacked out. He's standing there. It's like a 1960s picture. And this little 6-year-old kid has external genitalia like daddy, a sexually mature. We don't need little boys to have parts that are well developed like that, like you've already been through puberty. The kid is not fertile. That's why we call it pseudo-puberty. Precocious means it's happening too soon. Precocious pseudo-puberty means this 4-year-old, external genitalia-wise, is going to look like daddy. You know, this little kid, the picture that I got, I mean, here's this 6-year-old, looks like a porn star, is ridiculous. Not appropriate for that age. That's what this would do. What about you and me, sexually mature, post-puberty males? Tongue-in-cheek, what's it going to do to make you more manly? Technically, you would think nothing. Well, there are consequences, for sure. Unfortunately, testosterone poisoning has been linked often to aggression and kind of errant behavior patterns like that. But it's going to make you be more manly. Yay, sign you up, right? Say, give me, nah, not a good idea. Too many side effects. But isn't it funny how different population pieces and parts would be affected by this? Yeah. Us in the room, probably not so big a deal. You'll grow a mustache, we might get crazier. Not a big deal. To littles and underdeveloped and fetals, this is devastating craziness. Okay, that's the high end. Let's keep motoring. Man, let's do the low end. What happens if we are insufficient? Adrenal cortical insufficiency. Fancy way to say you don't have enough adrenal cortex hormones. The reason why we're putting this title up there is because we have an autoimmune disease. Heard of that? You know what autoimmune diseases are? Your own body's fighters are fighting your own body, which is stupid, but it happens. Primary adrenal cortical insufficiency is called Addisons disease. Addisons disease is really problematic, lethal if you don't treat and supplement. It is the autoimmune destruction of all the layers of your adrenal cortex, so guess what? You got none of the steroids. You don't have any mineralocorticoids. You don't have any glucocorticoids. And who cares about the gonadocorticoids? But you don't have them anyway. Is that a problem? Yeah, you'll see. This low end is far worse than the high end. What was the worst consequence in all the hypersecretions was I had high blood pressure, right? I had diabetes and Quasimodo ape face, right? You're not going to die tomorrow. It will shorten your lifespan. It's not a good idea, but this insufficiency side is way problematic to the tune of lethal. That's not common, thankfully. And if we find it, we have to fix it and supplement forever. There's secondary adrenal cortical insufficiency where we would have an issue with like hypothalamus pituitary axis, and when that's the case, we only see cortisol levels affected. Why don't I care about and see aldosterone levels affected? Oh, it's got these other means and mechanisms that stimulate it, right? Blood pressure, potassium levels, they're far more important than is ACTH. What would be the symptoms? If I didn't have enough aldosterone, if I was deficient in the mineralocorticoids, you're going to die. It's absolutely fatal. To the mink and bunny rabbits that we adrenalectomized for advanced physiology, if we did not give them doses of aldosterone, they were dead in a day or two. Every time. Why? Because if you don't have aldosterone, you can't maintain your ions. You'll present symptoms of hyperkalemia and hyponatremia. Do you know what those two words mean? What's kalium with a capital K? Potassium. Hyper means too much. Too much potassium is what and how we kill people. It's death by lethal injection. Did you know that? Like Texas, other places that use lethal injection to execute death row people. Strap them to a table, start an IV, push a bolus of potassium so that it destroys the gradient. Things don't, excitable tissues won't repolarize, and most especially after you push that bolus, you're dead in like 60 to 90 seconds. Because it's most sensitive and most effective on your heart. It'll disrupt cardiac rhythm, and your heart will stop, and you're dead, because it can't ever repolarize, can't ever have that because you've jacked with the gradient. Now there's no difference between inside and outside. Potassium's not going anywhere. Your heart doesn't ever repolarize. Is a bad deal and lethal. If that wasn't enough, hyponatremia, we don't have aldosterone affecting kidney tubules to reabsorb potassium and water, so all my sodium's going out in urine, and all my water's following it, so you're peeing like crazy to the tune that you reduce your blood volume. Become hypotensive, which in its worst case is shock, which also kills you. So this is a big deal. You cannot be without aldosterone. Not so true with the cortisol end. If we were deficient in cortisol, there's consequences, but it's not death. You will have a poor response to stress. You won't be able to deal with it as well. You will also probably be hypoglycemic. What does that mean? How does it feel to be low blood sugar? It's fantastic. Even when you couple that with dehydration, right? Nothing's better than being dehydrated and hypoglycemic at the same time. So you're funky, got the headache, and you're dizzy, and you can't think straight, and oh yeah, there's no blood glucose either. Your robot's not running very well. This is because I don't have cortisol stimulating my liver. The liver is the main key target here for gluconeogenesis, and blood glucose is going to take a hit. You're going to be hypoglycemic. You're also going to have a generalized decrease in metabolism, period, across everywhere. And oh yeah, you would present clinically with hyperpigmentation splotches all over you. How come? We already told you this. Here's how you spell it. Pro-opiomelanocortin, or POMC. Remember, fresh off of a ribosome, we have this POMC construct. We got to clip off this little piece and trim it. Here's ACTH that's going to go stimulate adrenal cortex to make cortisol. Here's the cast off, who's MSH, melanocyte stimulating hormone. And if I take cortisol out of the mix, if I don't have it able to be at normal levels, I lose the negative feedback. And without negative feedback, what's the pituitary going to do? Make more, make more, make more, make more ACTH. More and more MSH pieces show up. We see splotchy hyperpigmentations. We know that, oh yeah, you're going to go look at your cortisol levels. You're jacked and wacko, because that's where it comes from. That's why we talked about it, why you had to see it. It does have clinical relevance. Let's talk about stress for one more minute, and then we're done. Our bodies are designed to be able to deal with stress. We have to. If we couldn't deal with stress, the bear catches us and eats us. Yay, we're done, right? We have to be able to deal with stress. Look at where in your body your stress responses begin. Who is this guy? Heard of him before? The hypothalamus. He is the boss of the autonomic nervous system. He controls that sympathetic discharge, that norepinephrine is going to be released. Adrenal medulla is going to secrete the catecholamines, mostly epinephrine. We're going to have increased blood pressure, increased heart rate, increased respiration, fill my blood up to my muscles. Yeah, everything about fight or flight. right? For an immediate, but you know neuro doesn't last very long, short-term response to stress. Oh yeah, hypothalamus is the same dude who's in charge of controlling the whole endocrine system. So the same stress is going to stimulate more CRH, which is going to stimulate more ACTH, which is going to stimulate everything more from the adrenal cortex. And as a result of high levels of aldosterone, you're going to retain too much sodium, too much water, and you're going to have high blood pressure. Stress causes high blood pressure is an absolute fact. In addition to this high blood pressure, yay, let's sign up for hypertension and work my pump too hard. Stress via this pathway is also going to result in too much cortisol. Too much cortisol is going to make you diabetic. Stress causes diabetes is not a farce. It's a true statement. And in addition, glucocorticoids are potent, powerful, wonderful things at suppressing your immune system. Yay! So let's go ahead and suppress your immune system with way too high of cortisol levels so you get sick all the time. Stress makes you sick is also a true statement. Compare our world, how we're living, to 100 years ago. What'd they worry about 100 years ago? I don't want to be eaten by wild beasts. I got to plant my field and have my herds and my crops because I'm a subsistence for my job. I got to make my food because I got to eat my food because there wasn't Costco, right? Our world is not that. We don't take even a thought for what we're going to eat, where we're going to sleep hardly. We're spending all of our time out here in wacko land where they didn't have to deal with it. We are much more stressed. Stress starts earlier. Stress is not without consequences. If you stay stressed and don't ever come down and you keep this hormone cortisol way up high, you will be diabetic. You will have high blood pressure. You will get sick all the time for suppressing your immune system. You can't be right. So that's why we keep harping on you, man. You got to have some hammock time. You got to come down. It doesn't matter if you got to go punch a wall, go on a vacation, go live in a cave, whatever it takes to get stress gone. We require it. And if we don't, there's critical, hardcore consequences. Your body can respond to stress. Stress is not supposed to be ever present, always there, never going away. It's supposed to resolve. Here's the issue. Deal with it. Okay, it's over. That's not how we live. Think about it. We maintain way too high of levels of stress all the time with serious consequences. Never has there been such levels of obesity, such levels of hypertension, such levels of diabetes, such levels of immunosuppressant. We're sick all the time, as now, as a direct result from the stress that we live with. Stupid crazy. There's your soapbox for the day. Calm down. Unplug, man. Turn your phone off. All weekend, live the bliss. Let your body relax. And get out of stress. Put that away. We're done.